I'm Jack West, President and CEO of GRACE, the global resource for advancing cancer education. Here's the question and answer session following the presentation by Dr. Sequist, Assistant Professor of Medicine at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts. Dr. Sequist spoke on acquired resistance to EGFR tyrosine kinase inhibitors and the possibility of repeat tumor biopsies over time. She covers several questions offered in advance of her presentation, followed by a live Q&A component. This program is offered by GRACE in partnership with the Longevity Foundation.
Before we turn it over to any questions from people that are logged into this webinar, Dr. West had asked me to just give my opinion about a couple of questions. I'll just give you my opinion because there's no data. Are there ways to postpone resistance to erlotinib? The answer is we don't know. There are certainly a lot of studies that are ongoing looking at randomizing patients to Tarceva versus Tarceva plus fill in the blank. And the whole goal of studies like that is to see if whatever drug is in the fill in the blank can postpone resistance to erlotinib. And so some of those were the trials that I listed before. There's looking at HDAC inhibitors, looking at HSP90 inhibitors, HER3 antibodies. I think there's some trials using an anti-IGF treatment. So there's lots of things that are under study, but so far nothing's been shown to be able to do this yet. If you do progress on erlotinib, Tarceva, should you come off of that drug at the time of progression or stay on it? Again, there's no data about this, other than there is one trial that's been published by Memorial Sloan Kettering. It wasn't exactly this situation, but they did show that a small number of patients who had an EGFR mutation and then came off of Tarceva while they were being monitored, there was an increased flare in their tumor activity on a PET scan. So in other words, they had a PET scan while they were still on the Tarceva, and then they came off the Tarceva and had another PET scan that was hotter than one just a few weeks before. That, along with clinical experience of doctors seeing patients have an acceleration in the growth of their cancer, has made a lot of people excited about this concept of maybe just staying on erlotinib at the time of progression and adding other things to it, maybe things like Avastin or other chemotherapies, pemetrexed. So this is actually being done quite a bit in practice. There are many patients who are on, say, something like Alimta or pemetrexed together with their Tarceva. I have seen this strategy work very well in a number of patients, but there's really no data behind that. I think there is a downside to potentially staying on the Tarceva, and that is that we know that if you have a holiday from Tarceva, you can regain sensitivity. This has been reported in a number of different case series, and I think we've all seen patients like this where they came off Tarceva, they cycled through a number of different chemotherapies, and that after a year or more break with no EGFR inhibition, they circled back to the Tarceva and tried it again and had another good response. In some cases, that can last several months. Often, it doesn't last as long as the first response, but it can be an actual durable response. So there's been no study comparing these two strategies head-to-head, whether to stay on it or whether to give yourself a holiday in the hopes that you'll resensitize the tumor. I think that would be a very difficult study to orchestrate, so I'm not sure there will ever be a study like that. So I have no answer to that question. What are the practical considerations of getting a repeat biopsy? I think that there are many academic centers around the country that are studying this. Certainly we're studying at Mass General. I think that before putting yourself through a biopsy, you want to make sure there is going to be a good use for the tissue. You want to make sure that you have a mechanism of getting it tested in a way that can look for resistance mechanisms, and you're hooked up with a doctor who can advise you about what you might do with the results, basically steer you towards appropriate clinical trials, which may not be happening quite in the neighborhood where you live. It may mean traveling to another part of the country to try and be on one of these trials. I think it's kind of a cutting-edge approach. It's certainly not for everyone. It's certainly not easy or feasible for everyone. We don't know that any of these treatments work, are home runs yet, so it is a little bit of a gamble. That being said, I do think that there are a handful of patients out there who have dramatically benefited from this kind of approach, and I think the more we learn about it, the more accessible it will be for everybody. So this is the only way forward in my mind.
Thanks. So one question that came in is about, practically speaking, in someone who has progressed on Tarceva initially and has gotten actually some other treatment added to that, say Carbo and Alimta added to Tarceva after progression, and then they progress. How do you approach that? Do you reach a point where you decide that the EGFR inhibitor is not adding anything anymore? Do you continue that and switch out chemos from one line to the next?
I think this is a data-free zone where there haven't been any clinical studies looking at this, continuing erlotinib and switching out the treatments. That is something that's commonly done in breast cancer, again, without a lot of data behind it in breast cancer, but it is extremely common practice in breast cancer clinics to continue Herceptin and switch out the chemotherapies. I have a feeling that that's kind of the direction lung cancer is heading, data or not. So I think you could certainly do that. Most of the chemotherapies that we give for lung cancer are fairly tolerable when given along with Tarceva from practical experience, and I think that that would be very reasonable to do. Sometimes, if you have a situation that you can monitor closely, you could try a holiday off of Tarceva and see if that seems to make things worse or if there's no difference. One thing about Tarceva is that it is a hard medicine to take for years on end. Your skin gets very dry, your hair gets very brittle, you have problems with your fingernails and your eyes. And some of these clinical problems, symptoms, and side effects can really be much better, even after just a short holiday from the Tarceva. So I don't think that there's harm in stopping it for a short period of time in a closely monitored situation either.
Do you ever pursue a pharmacodynamic separation approach that has sometimes been advocated, the concept being that you don't overlap with the chemo and the EGFR inhibitor on the same exact days or two before the chemo, you'd stop it and resume it a day or two later?
I have picked up patients from other doctors who were already on that kind of pulsing strategy, and I continued it because that's what they were doing. I do have, in particular, one patient who's been on a strategy like that for a couple of years with really good results. But I also have other patients who I've just given the Tarceva. What I tend to do normally is just give the Tarceva straight without any breaks and give the chemotherapy in whatever schedule it should be every 3 weeks or something like that. So my normal thing to do is not to do the pharmacodynamic separation.
How do you think about a patient who was tested and found to have an EGFR wild type but ends up getting an EGFR inhibitor and having a very good prolonged response? How do you think about approaching things when they progress?
So there are a number of patients like that out there. And in the original New England Journal paper by Lynch talking about EGFR mutations, there was actually one patient in that cohort even who did not have an EGFR mutation but had a dramatic and prolonged response. So we've seen a number of patients like this. We always retest them for EGFR mutations to find out if maybe it might have just been missed. But I think what it tells us about the biology of that cancer is that it's dependent on EGFR signaling. It's very addicted to EGFR signaling through some other mechanism that we can't name what it is. It's not an EGFR mutation per se, but somehow the biology is acting very similar to that. And so I would actually approach that patient very much the same as I would someone with an EGFR mutation.
Can you speak to the issue of the timeline or the arc of progression once people have developed EGFR-acquired resistance? And this was addressed a little bit and actually kind of nicely in terms of what we know right now from the Memorial Sloan Kettering publication.
I think the take-home point from that paper by Oxnard in Cancer Clinical Research is that there are a number of people who can get continued benefit from staying on Tarceva if they're having a slow progression. And I think why people really like that Oxnard paper so much is it kind of gave credence to what we see in the clinic. And so clinicians who've treated a lot of patients with EGFR mutations will tell you that they already knew this, that they knew there were kind of two beasts. There's one where you have a very quick progression and you got to do something else because the cancer has woken up. And there's another type of progression that is extremely slow and indolent. And for those patients, you can keep them on Tarceva for many months, sometimes even more than a year, before you're really pushed to do something else. What we do know from the Oxnard paper is that if there's no T790M, it's likely to be a little bit faster progression than if there is T790M. But not all T790Ms are this slow progression. But if you are having slow progression and your doctor is telling you to stay on Tarceva because the progression is slow enough, that's a very reasonable thing. They're not crazy.
If someone has a biopsy at the time of acquired resistance and does have a T790M mutation, does that make you any more or less inclined to continue the EGFR inhibitor?
Before the Oxnard paper, I would have said no more or less inclined. I would just base it on clinical judgment as to how they were doing. But actually, because their paper showed that there was this indolent type of T790M, it actually now might make me more inclined to continue the inhibitor.
The question comes in about newer irreversible tyrosine kinase inhibitors as opposed to Iressa or Tarceva, and is there any sense that starting with one of these will extend the time until progression and postpone acquired resistance, or do we have no data on that, or what's your knowledge or understanding of irreversible versus reversible TKIs and acquired resistance timing?
I don't think we have a huge amount of data on that yet. I think probably the largest study is with the IBW2992 or fatinib. It's a study called the Lux-Lung-2 study that is led by James Yang, and it's been presented at a couple of different meetings, but not published yet. Not everyone in that study was first line. Some people had had prior chemo, but there were a good number of patients. Everyone in the study had an EGFR mutation. There were a good number of people who went on to the fatinib as first-line treatment. And it looks like, from what's been presented at meetings, the progression-free survival or the duration that they were on the treatment is upwards of a year, maybe 14 or 15 months, which is a little bit better than we typically see with Iressa or Tarceva. So I think there is reason to hope that these new drugs may prolong the benefit. There are a couple of studies that are ongoing with some of the other second-generation drugs that we'll see if it's a class effect or if it's specific to a fatinib. But I think there is some hope to that. Unfortunately, none of those second-generation drugs are FDA approved yet, so you have to participate in a clinical trial to get them.
If you do continue erlotinib, Tarceva, say, and then add Avastin or add chemo to that, have you encountered any difficulties with either getting coverage for the new agent or continuing the Tarceva?
I have not, but if I go around the country and give talks to different people, I have realized that I think the insurance situation in Massachusetts must be better or more lenient than in some other parts of the country, because I definitely have heard stories from many of my colleagues about how difficult it can be in that situation. So I think it just depends on the patient's insurance and how they operate.
Can you comment on how much or how little variability you think there might be in the location of one biopsy over another and just cancer heterogeneity? In other words, are you concerned that whether you biopsy in one part of a cancer versus another or in the liver metastasis versus a lung nodule, that you might see very different results and be led down a different path?
That's a great question, and I think we don't fully understand the answer yet. There's been at least one autopsy case that I've seen reported where there were divergent resistance mechanisms in different parts of the patient's body. So one area had MET amplification, one area had T790M. So a case like that does make you worry that if you just do one biopsy, you could be misled or you could be making an assumption that's not exactly true. But I think to some extent, if you're a doc or a patient who's considering one of these biopsies, you have to biopsy something that's feasible, something that's safe, and ideally you'd like to biopsy something that's growing, the site that's most likely to show the resistance mutation or resistance change. I can say for this small cell phenomena, unfortunately one of our patients that we found this in did pass away, but did donate her body for an autopsy so that we could learn more. And in that particular patient, in every spot of cancer that we found in her body was all small cell and it all had an EGFR mutation. So that suggested that there was some kind of master change that went on that was uniform, with the exception of a brain met that that patient had, which was still adenocarcinoma at the time of her death.
Thanks so much for taking the time to go over this with us.
Sure, thank you for having me.